For those of you that don't know me, my name is Andy Rennie. I am the Education AHA Coordinator for Lancaster MS, and I'll be talking to you this evening for about the next hour on neonatology. Now, I will try to get through as much as I can, but I did ask Rick to send you a copy of my PowerPoint, plus also 4 separate handouts regarding specific cardiac anomalies with a neonate's heart. I'm hoping you guys got them. Hi, Brandon. So neonatology, one of the big things that I will say to you both in neonatology and in pediatrics is that children and infants are not little adults, and you will hear that more and more when you deal with pediatrics. They have very unique needs. Excuse me. We're going to talk about the newborn, the neonate. They are completely dependent on others for everything, for nourishment, for warmth, for protection from the environment, for everything. And they are delicate, fine pieces of china and need to be taken care of appropriately. General pathophysiology and assessment. Their additional skilled care intervention is needed for approximately 6% of newborn deliveries. It varies as far as percentage, but more than 90% of the time, births go well. And then you have that other 6 to 10% that do not. The rate of complications increase as the newborn's birth weight and gestational age decreases. So the younger they are, the more likely they are to have complications. So here are some risk factors for prior to birth, antepartum, multiple gestation or multiple babies, pregnant women less than 16 or over the age of 35, post-term or greater than 42 weeks of gestation, which would really be a bad thing, toxemia, hypertension, diabetes. I'm sure you guys have all heard of gestational hypertension, gestational diabetes. It just kind of shows up when they're pregnant, when the mothers are pregnant. Polyhydramnios, excessive fluid or amniotic fluid, premature rupture of the membranes, and fetal malformation, inadequate prenatal care. Sometimes we see that, especially here in Lancaster County, maybe Southern York County, Upper Dauphin County, with the Amish population. History of perinatal morbidity or mortality, where we have a history of babies that are miscarriages or babies that have died of other medical anomalies. Use of drugs or medications during pregnancy, fetal anemia, or decreased amniotic fluid during pregnancy, or when a woman gets really dry as far as amniotic fluid. Intrapartum or during birth, risk factors, premature labor, rupture of the membranes, longer than 24 hours before the delivery actually occurs, an abnormal presentation. We all hate that. And as far as presentations, for most of you, or some of you that I have tested before, when you become employees here, I use a specific scenario regarding the birth care center in Bart Township regarding a breech birth. And for those of you, just to remember kind of in OB, when babies are born, they're born face down, head down. Any variation from that is considered a breech birth. So if the baby is head down and face up, it's still breech, but that's the best of all of them. Obviously, we have arm and leg presentations. And then one I had recently down there was actually a butt presentation where the baby was actually folded in half and almost kind of doing some yoga inside. Mom was coming out butt first. That was a bad thing. Prolapse cord, meconium, narcotics within 4 hours of delivery, precipitous deliveries, bleeding or placenta previa. Any of that stuff that goes on during birth are risk factors for problems for the baby. Transition from fetus to newborn is kind of an important stage that happens. In utero, the fetus receives its oxygen from the placenta. The fetal lungs are actually collapsed and filled with fluid. The causes and delays in transition can be hypoxia, which is kind of the number one problem with newborns, meconium or blood aspiration, acidosis, babies being hypothermic, some type of pneumonia, or hypotension. Fetal transition, newborn's lungs need to expand with air within seconds of at least head presentation. As the lungs fill with air, pulmonary pressure drops and blood begins to flow to the lungs. This is a very important stage in transitioning from the mother circulation to the fetal circulation. Anything delaying this could lead to hypoxia, brain damage, and ultimately death. It's super important for this to happen within the right amount of time. Transition from fetus to newborn, again, gestational ages and terms you should know. Preterm obviously means before their term, less than, say, 38 weeks, 38 to 40 weeks. Term is 40 weeks, and post-term is anything greater than 40 weeks. Change if more than one fetus is in the uterus, so it can full term for twins or triplets could actually be 36 weeks. It just depends on the number of babies and how far along mom is and any other comorbid factors. Key questions once baby is coming. Has the mother received any prenatal care? Have they been taking any prenatal vitamins, folic acid? Have they seen a physician or at least a certified nurse midwife? What is the age of the mother? How long has the pregnancy been? Like how far along is she? Presence and frequency of contractions, presence or absence of movement of the fetus, whether water has broken or membranes have ruptured, and were there any medications that were taken within the last 12 to 16 hours prior to contraction starting. Obviously, get your equipment ready. You're going to need warm blankets, dry blankets, a bulb syringe, 2 small clamps or ties, and a pair of clean scissors. Delivery in the ambulance, we want to make sure that we're not in movement, that the ambulance is stationary, pulled off to the side of the road, and we are delivering in a stable environment as much as you can make it stable. The foot of the bed can be used for initial stabilization steps. After confirming the airway, breathing, circulation, the newborn can be dried, stimulated, and put on the mother's chest. Second ambulance equipped with neonatal transporter, incubator, whatever, or second ambulance should be called. Now, I know all of you are not Lancaster Honest employees. You are from different parts of the region and state, but it's very clear that we cannot, for safety reasons, transport mothers and newborns in the same ambulance together. Unless you have the ability to have 2 litters in the back of your rig, which there are some out there. I understand that. But the bottom line is, as difficult as it is for all of us to accept that, the bottom line is we have to worry about safety and liability. One of the things I have found that has helped me out when I've had to do that is to make sure that, I let the mother and parents know ahead of time that if the baby is born in the back of the ambulance, that we would be calling a second ambulance to transport the baby. If the mother and the father are together, I send the father along with the baby and make sure that the ambulance that has the baby is behind the one with the mother so that she can sit up and she can see that ambulance, and it gives her a sense of security knowing that her husband or significant other is with their baby and that they are going in the same direction. She can physically see it. So that's what has helped me in the past. If the umbilical cord comes out ahead of the baby, we're going to have potential some issues. It's more common with patients that have polyhydramnios, which is increased amniotic fluid. The blood supply through the umbilical cord may be cut off and could potentially cause problems for the baby. Relieving pressure on the cord can be life-saving. I'm hoping that when you went through OB, we did talk about I hope that you talked about the skill where you are permitted in two certain circumstances to actually insert a gloved hand inside of the vagina to take pressure off the cord, or with a breech presentation where you can go in and you can make a pathway for air and kind of hopefully clear the baby's airway if it's a breech birth, and get the airway at least somewhat open for the child. When the baby's head is delivered, suction the mouth and nose with a bulb syringe. Obviously, depress the bulb syringe, insert it, then relieve the pressure and sucking it out. We all will get kind of beside ourselves and need to keep in mind that we're not pushing the bulb syringe into the nose and then depressing it, where we're actually blowing the mucus and the whatever fluid is in the baby's nasal passage or mouth down into their lungs. We want to suck it out. Keep the baby at the level of the mother if at all possible. We don't want to keep him or her below the mother or above the mother, so where they can become super engorged with blood, or they can actually have blood drain back into the placenta and become hypovolemic. Initial rapid assessment may be done simultaneously with any treatment interventions. It's important to note the time of delivery. Obviously, monitor any airway, breathing, circulation, respiratory rate, respiratory effort, pulse rate, color, and cap refill. These are all important things need to be looked at and documented within the first minute of life. We're going to talk about APGAR scoring here in a few minutes, but that information is very important. Vigorous term babies nearly 90% of the time, which is great. Position the baby to ensure a patent airway. If you notice in the diagram, you have that the baby is face up, being supported by the forearm and hand. The back of the head is supported, and the baby is somewhat pointed downward to kind of help keep airway open a little bit. Clear the airway and assess the baby's color. But one thing that's also vitally important that's not in this picture is making sure the babies are dried and kept warm, because they have very little ability to manufacture or stimulate their own heat production at birth. Help determine the needs. The APGAR score helps determine the needs for the effectiveness of resuscitation. It was developed in 1953 by Dr. Virginia APGAR. Obviously, most things that are new in medicine are always named after a physician. It's done on the basis of the newborn's condition at minute 1 and minute 5 after birth. So the things you want to look at, the APGAR score stands for appearance or skin color, pulse rate, grimace or irritability, activity, muscle tone, and respiratory effort. So, and we score them accordingly. There are 5 different parts. The best you can get is a 10. So if appearance, if they're completely pink with no dusky, pale, blue, gray areas, both centrally and peripherally, they would get a 2. If they have some duskiness in the extremities, which is not unusual, they would get a 1. Pulse rate, greater than 100, a 2. Less than 100, a 1. Completely absent, 0. Grimace or irritability, if the baby cries and seems to be functioning, seems to be irritated, which is great. Crying babies are good babies because they have good airways. Crying equals a 2. Grimacing with not a whole lot of sounds is a 1, and no response at all is obviously a 0. Activity would equal active motion. Babies, when you pull their hands, they're kicking their feet a little bit, moving their arms and legs. might be moving their head a little bit, not a whole lot, but smacking their lips, even opening their eyes would be active motion. That would be a 2. Some flexion of the extremities, but not so much movement, would be a 1, and then no movement or being very limp would be a 0. Strong cry for respiratory effort is great. Again, loud babies are more stable babies. Slow and irregular respirations are concerning, may need some intervention. They would get a 1, and then obviously any absent respiratory effort would be a 0. The need for resuscitation. Not all deliveries will go smoothly. Approximately 10% of newborns need some type of assistance. Only about 1% of those need to have major resuscitative efforts to survive. An algorithm developed by the American Academy of Pediatrics and the American Heart Association. It's called NRP, Neonatal Resuscitation Program, which is a phenomenal program. Once you guys get out and get graduated and get somewhat settled, if any of you are interested in pediatrics, I would highly, highly suggest that you try to find an NRP program. NRP is very specific and has to be taught by a neonatal nurse. It is, again, a joint venture between the American Academy of Pediatrics and the American Heart Association. Unfortunately, the American Heart Association training centers cannot teach that class without having a neonatal nurse or a neonatal physician on board to actually teach it. Interventions and assessment and determination of need are extremely important, but doing your visual assessment and recognizing any problems with airway breathing, circulation, or muscle tone, lack of cry, will give you clues to whether or not you have to intervene or not. If the newborn has not responded, count the respiratory rate and pulse rate for 6 seconds and multiply by 10. Just a quick down and dirty way to get at least some type of respiratory and pulse rate. Look for any kind of acrocyanosis. Provide supplemental free-flowing oxygen as a stimulation to the baby. Blow-by oxygen or a couple little puffs with a bag valve mask might be enough just to stimulate them to increase their own heart rate and respiratory drive. If the patient is apneic or has a pulse of less than, should be 80 beats per minute, begin positive pressure ventilation, bag valve mask with a bag valve mask device. Use caution when squeezing the bag. We certainly don't want to blow their lungs out. They are very delicate, and we want to stimulate their breathing. If necessary, if heart rate goes below 60 to 80, then we want to start chest compressions. Bradycardia happens in fewer than 1% of deliveries, but it is the most common etiology is hypoxia. So again, as most of you should have been taught in EMT school, the majority of problems with children come from respiratory problems, and that comes right from birth. Hypoxia is the #1 problem that causes problems for kids. Tension pneumothorax is also a possibility. Excuse me. So we want to make sure that we're getting good lung sounds, good lung aeration. Newborns are resilient, but their lungs are also very brand new, and they can't take extra pressure. So we need to bag them if we have to, just enough for chest rise and chest fall. After ensuring patency of the airway, we want to make sure that we dry and stimulate the infant. If you do take the NRP program, they very much teach you to do dry and stimulation first. But it is within the first few seconds of life, we need to make sure that first few seconds of birth, that we're multitasking. We're clearing the airway, we're suctioning the airway, we're drying, we're stimulating. Stimulation is not slapping the baby on the backside like everybody thinks is funny. It is flicking the soles of the feet, gently rubbing the baby's back. Avoid rubbing too roughly because, again, they are brand spanking new. Be gentle, but be enough to stimulate. No slapping. If the patient is cyanotic or pale, provide supplemental oxygen. If we have the ability to do warm or humidified oxygen, great. Most pre-hospital ambulances do not have the time for that setup. The flow rate should be set at 5 liters per minute, or we don't want to overdo it. So if we are using a pediatric or neonatal bag valve mask, we want to make sure that we are just enough for chest rise and chest fall, not too much pressure, but getting good oxygenation. The use of oral airways are rarely needed for neonates. There's a picture down there at the bottom. We've got bilateral coronal atresia. It's a bony membranous obstruction of the back of the nose, preventing airflow. Babies and infants are obligate nose breathers, but if you see that you're not moving air through the nose, this may be a problem. So using an oral airway might be necessary for this type of problem to keep the tongue out of the way so that you can bag the baby appropriately through the mouth. This can be rapidly fatal and usually responds well with the placement of an oral airway. But there's really no way of knowing this without radiographs or x-rays. But if you can't pass oxygen and there's some kind of blockage, obviously there might be a problem you need to address. Pierre-Robin sequence, a series of developmental abnormalities or anomalies. If you can see the picture down below to the right, there's a small chin and posteriorly positioned tongue. Frequently leads to airway obstruction. It's something that is kind of a lifetime thing. Some of these kids do really well, and others do not. But if you notice it, it's very kind of sticks out when babies are born with kind of a small chin. You'll be able to notice that right away. Sometimes getting a good seal with a bag valve mask is difficult for these kids as well. Respiratory distress or BVM usage, obviously if patients are apneic or not breathing, inadequate respiratory effort if they're breathing but not adequately, color is not changing, or they are breathing too slowly, or their pulse rate is less than 100 beats per minute, they might be starting the whole bradycardia trail. So we want to bag them to get that heart rate up. If their heart rate gets lower than 80 beats per minute at a newborn stage, we should be starting chest compressions. Signs indicating bag valve mask ventilation, obviously periodic breathing or no regularity, intercostal retractions, nasal flaring, grunting on expiration. Common causes of respiratory distress in kids: lung or heart disease, which could come from any one of those 4 cardiac anomalies that I had sent to you guys, or had Rick send to you guys. Central nervous system disorders, a pneumo, meconium aspiration or inhaled baby poop, lung immaturity, which is something that does happen more often than not. One of the last things that does develop in newborns is their lung capacity and their lung fields, and sometimes they have to have a medication or something called surfactant to actually permit their lungs to actually expand and actually function properly. Shock and sepsis could be a problem. A diaphragmatic hernia, which you'll see a picture of in a little bit, where actually the diaphragm is separated, the muscle itself is separated, and the organs of the abdominal cavity are actually up in the chest. Persistent pulmonary hypertension or increased pulmonary hypertension, mucus obstruction of the nasal passages, which is something that we could all take care of with suctioning. Coronal atresia, amniotic fluid aspiration, pneumonia, and metabolic acidosis. 3 different devices. We have a self-inflating bag with oxygen reservoir. a flow inflating bag or a T-piece resuscitator. Self-inflating bag, most likely used in the field, which we're all kind of used to. Only 1/10 of the bag's volume will be used for each breath, depending on what size bag you use or BVM you use. Again, just enough for chest rise and chest fall. Just simple little puffs, just very delicately, would be in everybody's best interest. When administering, make sure we have a good airtight seal, that the airway is patent. The first few breaths after birth may require a little bit extra pressure, but again, just enough for chest rise and chest fall, but visible but not excessive chest rise. Timing for ventilation could be anywhere between 40 to 60 breaths per minute. We count, breathe, 2, 3, breathe, 2, 3. It's not the same as when you're doing normal rescue breathing for a child or an adult. This is specifically at birth. Indications for intubation. Meconium staining is present and the infant is not vigorous. The meconium can be very thin and might be able to just be suctioned out, but if meconium is very thick, dark colored, can be very difficult and can obstruct airway tubes. So intubation may be your only choice. A congenital diaphragmatic hernia is something that would absolutely need to have an intubation. If you're hearing lung sounds on one side and bowel sounds on the other, there's a problem. Infants do not respond to BVM ventilations and chest compressions. Would be an indication for intubation. Prolonged positive pressure ventilation is needed to keep the lung fields open. Equipment, obviously suction, laryngoscope blades 0 and 1, a shoulder roll, adhesive tape, and obviously endotracheal tube with a stylet or a bougie if you have a pediatric size one. Gastric decompression. I believe this is a really good thing to have on hand, especially at the birth of a newborn. Indicated in the following situations where there's prolonged BVM ventilation. Abdominal distension is impeding ventilation, where there's too much belly air and potentially could be causing problems, and stopping the flow of oxygen and air into the lungs, or again, the presence of a diaphragmatic hernia. Chest compressions, indications, pulse remains less than 80 beats per minute, despite proper positioning, clearing an airway, drying and stimulation, and 30 seconds of effective positive pressure ventilation. If that's the case, then we need to get on the chest and start chest compressions. There are two different techniques as approved by the American Heart Association. The two-thumb circumferential technique is used for multiple rescuers or at least two rescuers, where one person's positioned to head, the other person's positioned down to body, and you're actually able to get your hands completely around the infant's chest and use your thumbs as the compressing part. Two thumbs are placed over the sternum. If you are by yourself, the two-finger one rescuer technique, we're using your index and forefinger, and you're placing it over the sternum, just below the nipple line, to do chest compressions. The depth of compressions is 1/3 of the anterior diameter of the chest, synchronized with artificial ventilation. Compression rate is 100 to 120 compressions per minute. And again, compressions and ventilation ratio is 3 to 1. Coordinate compressions with ventilations, minimize interruptions and compressions to less than 10 seconds. I would say no more than 5 to 10 seconds. It is possible to have liver lacerations and to also fracture ribs. However, ribs are much more pliable in newborns than they are adults. So again, if you're not too overly aggressive, you should be okay. Remember, they are brand spanking new. Venous access, necessary for fluid administration to support circulation. If you think the child is hypotensive are hypovolemic to the point that you need to intervene, then fluid resuscitation might not be a bad idea. Resuscitation medications must be administered intravenously or intraosseously. Therapeutic drugs must be given IV. Now, in Pennsylvania, I will tell you the umbilical vein catheterization has been taken away, but since there is no real command line, I'm still going to talk about it. The umbilical vein can be catheterized. We clean the cord with alcohol or another type of antiseptic, like maybe betadine. Place a sterile tie firmly around the base of the cord. Pre-fill a syringe, a sterile 3.5 to 5 French umbilical vein line catheter with normal saline, if you have such a thing. If you do not, you can also use a 18 gauge or 20 gauge angio. Preferably the longer the better. A decompression needle, chest decompression needle, 14 or 16 gauge 3-inch needle would be good, as long as you can fit it within the diameter of the vein that you're trying to cannulate. Here's a picture for any of you that remember years and years ago, the old Saturday Night Live. There used to be a skit called Mr. Bill. Well, when you do a cross-section of the umbilical cord, it does kind of give you a smiley face. There are 2 arteries and 1 umbilical vein that's kind of shaped like a half moon. That's what you're aiming for. So you want to cut the cord, kind of do a, do a cross-section of the cord with a scalpel. Insert the catheter into the vein that's the half smiley face, approximately 2 to 4 centimeters, or as far as you can if you're using an IV catheter. Flush the catheter with normal saline and try to tape it and secure it in place, which means you would need to also kind of dry the umbilical cord, but still make sure that it's open enough to be patent. You should be able to withdraw some blood, but keep in mind the baby has a very small amount of circulating blood volume, and the purpose of doing this is to give them fluid to begin with, so there's already a problem. Pharmacological interventions are rarely needed. Most infants can be resuscitated with ventilatory support. Medications are based on weight, which that's what we use the Broslow tape for, or the colorimetric weight-based color-coded tape, or PD wheel. Epinephrine is one of the things that one of the medications you should memorize as far as initial dose of epinephrine is indicated when an infant has a pulse rate of 60 or less after 30 seconds of effective ventilations and 30 seconds of compressions. The recommended concentration is 1 to 10,000, but we're kind of getting away from that. It should be administered via IV or IO. Medications via an endotracheal tube, again, are not recommended, are an absolute last resort. But if you, for some reason, would have to administer medications through an endotracheal tube, it should be done at a volume of 2 to 2.5 times the IV dose. But again, absolute last resort for ET tube administration of medications. Volume replacement, significant intravascular volume depletion, owing to conditions such as placental abruption or septic shock. A low umbilical vein line or peripheral IO, IV or IO line would be great. Fluid boluses at 10 milliliters per kilogram of normal saline, given over 5 to 10 minutes. We don't want to overload them right away, but we want to try to give at least a 10 ml per kilogram bolus and then reevaluate. If need be, give a second, but also make sure we're talking to command and let them know the situation. Sodium bicarbonate may be indicated in the presence of acidosis. Obviously, we need to contact medical command. Initial doses of 2 milliequivalents per kilogram of the 4.2% solution IV over 5 to 10 minutes. It is not good for rapid administration like we may be used to for adults. Respiratory suppression secondary to narcotics, drug-addicted mothers. I can say from personal experience, I have a grandchild that was born with fetal abstinence syndrome, that my granddaughter's mother was taking narcotic medication at the time she was pregnant, and unfortunately affected my granddaughter. Narcan was given. Luckily, there were no seizures, but unfortunately, she does have some lasting effects from it. But if it looks like narcotic overdose, signs and symptoms could be the same: decreased respiratory effort, pinpoint pupils, a good history, looking at the mother, would be good indicators for you to decide whether or not you should be giving Narcan. Pneumothorax evacuation, if signs are present, severe respiratory distress, unresponsive to positive pressure ventilation, obviously unilateral decreased breath sounds or a shift of heart sounds, which may be somewhat difficult in such a small sized chest of a newborn. You can pretty much hear everything from one side to the other, but if you have a marked difference from one side to the other, as well as severe respiratory distress, you see one side of the chest expand where the other one does not necessarily expand as well, then common sense would lead you to believe that you may have a pneumothorax. So treatment for that would be the same as it would for a child or an adult. Needle evacuation, obviously clean around the area around the second intercostal space with betadine and alcohol. Prepare the equipment. 22 gauge butterfly needle attached to extension tubing would be good. A 3-way stopcock and a 20 ml syringe to help evacuate the air. Insert the needle above the second rib as the second provider pulls back on the syringe. This is kind of a two-person technique if necessary, or if you have that luxury of having two people. Continue to slowly advance the needle until air is recovered. And you could also have a symptomatic ongoing air leak. Meconium-stained amniotic fluid has a very high risk for morbidity or mortality. It is in the presence of 10 to 15% of deliveries. Either before or during the delivery, the baby has its first bowel movement. It is more common in post-term infants and are small for their gestational age. So small babies that are born after 40 weeks, and airway becomes plugged or clogged with meconium depending on the consistency of it. It can be very stringy, it can be very thin, it can also be very thick. And airway becomes occluded, and hypoxia will ensue very quickly. Delivery with meconium-stained fluid, determine whether the fluid is thin or green-stained versus thick, and have particulates or is chunky, if you will. If the baby is crying vigorously, employ standard interventions. If you need to suction, keep the baby crying, keep the baby vigorously breathing. If the baby is depressed, do not dry or stimulate him or her. Work on the airway, intubate the trachea, attach the meconium aspirator, and a suction catheter. Suction the ET tube while withdrawing the tube from the trachea. The best thing to do if you have the availability of multiple tubes is to do one pass, take the endotracheal tube, get rid of it, put a new one on. However, if you do not have that ability, making sure that you clearly clean and clear out the meconium out of the tube before reintroducing it back into the baby's airway. After suctioning and getting the airway open and getting the meconium out as best as possible, dry and stimulate, provide oxygen and positive pressure ventilation to, again, just enough for chest rise and chest fall. Here's a picture of a diaphragmatic hernia. It's an abnormal opening in the diaphragm, more commonly on the left side. But what you can see, those little rolls and those little, what seem like squiggles in the baby's left chest, is actually their large and small intestine is up. I mean, it's almost up at the clavicle, which is up around the mediastinum. There's probably no air movement on the left side at all. It happens in approximately 1 in 2,000 to 2,500 births. Diagnosis is often made prenatal, ultrasound before the baby's birth, but can also happen just hours before birth. Mortality can be as high as 50%. Management. BVM ventilation introduces air and that distends the intestines. If positive pressure ventilation is needed, place an endotracheal tube. Put an OG tube in place if you have that ability, and intermittently suction the newborn. Ultimately, this will require a surgical correction. Prior to coming to Lancaster EMS, I did spend approximately 10 years up at Penn State Hershey Lifeline as a critical care medic with the pediatric critical care team and the flight side. Spent a lot of time in the NICU and PICU and saw this more often than not. But surgical intervention, as soon as the baby gets to a PICU, or I'm sorry, as a NICU, and neonatology can take over, babies can live a long, uneventful life with this particular problem. Is common in infant, or apnea, I'm sorry, is common in infants delivered before 32 weeks gestation, rarely seen in the first 24 hours after delivery. If prolonged, can lead to hypoxemia and bradycardia. So airway status is extremely important. Pathophysiology of apnea depends on the underlying etiology. It could be apnea of prematurity because they're just too premature and their lungs have not fully developed. The gastroesophageal reflux could be drug-induced. Respiratory support to minimize hypoxic brain damage as much as possible. Obviously doing an assessment and careful history, physical exam focusing on any neurologic signs or signs of infection. And one thing that you may almost always never see in a newborn is a fever with infection. So because they don't have the ability to do that yet, they will have primary and secondary apnea. Drying and stimulation is not as important as bagging them, but ultimately getting them wrapped and conserving body heat is important. If you suspect a coronal atresia, you need to place an oral airway. Obviously, we talked about the Pierre-Robin syndrome or sequence. Position the infant prone and maintain the airway, and use an oral airway if you feel it's needed. Just wanted to make sure we also recognize the fact that putting in an oral airway in an infant or child is completely different than putting it in an adult. We do not want to do the traditional, we want to measure it the proper way from the corner of the mouth to the earlobe or the corner of the jaw. And then we want to actually open the airway, head tilt, chin lift, open the mouth and slide it in the side of the airway of the mouth, above the tongue, rather than going in upside down, hitting the roof of the mouth and turning it. It would be better to go in the side. If you have a tongue depressor, to make sure that the tongue is kept back and not down in the airway and flop back and get the oral airway on top of the tongue, that would be great. Cleft lip or cleft palate. Airway resuscitation is usually not needed. Cricoid pressure if intubation becomes necessary, because we have this whole opening and the upper palate is open. Nasal passage depends on how significant or severe the cleft palate or cleft lip is. PPV ventilation via bag valve mask should be considered. And there's also a risk of aspiration and regurgitation. So again, over-aggressive ventilation can be detrimental. Additional conditions: exposed abdominal contents, which does happen like in 1 in, I believe, 6,000 births, where actually the abdominal contents are actually still outside of the abdominal cavity. It's almost, babies are born with abdominal eviscerations, if you will, where their organs are outside. It's a developmental defect. Place the baby from the waist down in a sterile, clear plastic bag if possible, to keep the bowel clean and minimize the loss of fluids. Monitor the color of the intestines as best you can. The brighter they are, the better blood flow is getting to them. But one of the big things is to be as delicate as possible. We don't want to perforate a bowel that's outside, cause more problems for the baby. The treatment for this is actually pretty simple. Depending on the severity, what they'll do is they'll spend a lot of time in a NICU, and the babies will be kept in a warmed incubator, and the abdominal contents will be suspended above them in a cheesecloth, kept moist with saline, and will allow the body to pull the abdominal contents back in at its own rate. It's kind of interesting to see. Babies usually spend several weeks or several months in the NICU, depending on the severity of this particular problem. But usually the body will pull these organs in on their own and will ultimately put them in the right place. And then the babies are sutured up and monitored, and then ultimately they go home. So it's actually a pretty neat process. Premature and low birth weights are kind of a big deal. You can see the big difference there. Both babies are the same gestational age, but obviously different birth weights. Prematurity delivered before 37 weeks completed of gestation. So 36 and 6/7 weeks are still premature. 37 and above is not. Low birth weight, less than 5.5 pounds. Most common etiology is, again, prematurity for low birth weight. Factors of prematurity are genetics, infection, cervical incompetence, meaning the mother's cervix is a problem with the mother's cervix, and placental abruption. Continued factors of prematurity: multiple gestations or multiple babies, previous delivery of a premature infant, any kind of transient drug use, and obviously any kind of trauma. Factors for low birth weight: chronic maternal hypertension, smoking by the mother, placental anomalies or abnormalities, and chromosomal abnormalities. Preterm happens in approximately 12% of the United States. Morbidity and mortality related to morbidity and mortality are related to the degree of prematurity. So the younger and smaller they are, or the lower gestational age they are, the higher chance they will have other problems and or will die. Delivered at 24 weeks or higher, 24 weeks or below, have a higher mortality and morbidity rate. Is personally, from what I learned at Hershey and with other interactions with Children's Hospital Pittsburgh, Children's in Philly, and AI DuPont, is that the youngest that I know of a child surviving being born early is at 23, it's like 23 and a half weeks. There may have been others, but I'm unaware of that. Premature birth weight, deliveries in the field, cardiorespiratory support, and a thermo-neutral environment is important. There's a higher risk for respiratory distress because of underdeveloped lungs, weak lungs, and retinopathy of prematurity, problems with the retinas being detached and not being completely formed yet can cause visual problems for the babies down the road. Okay, seizures in the neonate, they're the most distinct sign of neurological disease. Paroxysmal alteration in neurologic function gives you an indication there is something going on. More common in premature infants, obviously, and they're identified in the field through direct observation of the baby. In the hospital, they are diagnosed by an electroencephalogram or EEGs. If they feel that mom was, say, preeclamptic and clamptic, babies could also have neurological issues as well, so they will monitor them. Seizures in the neonate may exhibit normal motor activity, sometimes mistaken for seizures. I'm sorry, their normal motor activity might, what you would consider abnormal may be normal for a baby. Rapid arm movement or maybe some minor shivering here and there. Babies getting used to their temperature because they're not able to really, they've been in a 98.6 degrees or 99 degree bath for the last 9 months. And all of a sudden they're coming out to a cold environment. Usually babies can't shiver, occasionally they can, but it also could be mistaken for seizure activity. Myoclonic dysconjugate eye movements or sucking movements, jitteriness. Now, normal sucking is great. Babies are prone to do that, but in the presence of other things like what you consider shivering or seizure-like activity, dysconjugate eye movements would lead you to believe that the baby's having seizures. Types of seizures, 4 major types: subtle, tonic, focal clonic, and myoclonic. Describing seizures: multifocal, generalized. The causes of neonatal seizures include hypoxic ischemia, encephalopathy, intracranial infections or meningitis, hypoglycemia, other metabolic disturbances that you can't figure out, epileptic syndromes that you would not know about, intracranial hemorrhage or head bleed, developmental defects, hypocalcemia, which again, unless you're running lab work or point of care testing, you're not going to be able to figure that out pre-hospital. Causes of seizures: hypoxic ischemic encephalopathy, usually secondary to perinatal asphyxia, which can come from a prolapsed cord or some type of problem with the umbilical cord pre-birth. Single most common cause of seizures, characteristically occurs within the first 24 hours of life, and is sometimes accompanied by metabolic abnormalities. Hypoglycemia, it is most frequently seen in infants. They are small for their gestational age or large for their gestational age. Mothers can be diabetic or were diabetic or are diabetic during pregnancy or are existing diabetics, which could cause problems for babies. Hypocalcemia, 2 major peaks of incidence. First occurs within 2 to 3 days after delivery. However, it is a late onset and rare in the United States. Assessment and management of seizures: evaluation, quick evaluation of prenatal and birth history and physical exam. We have a quiet, often hypotonic infant or one that doesn't move around a whole lot. Might even actually seem to be lethargic or limp, but still has decent color. Maybe lethargic or apneic. Hypoglycemia must be recognized quickly and treated promptly. Blood sugar is somewhere around the number of 40 is good to have a starting point. Have blood glucose measurement and administration of dextrose. D10 is the preferred medication, obviously, but contact medical command. Obtain baseline vital signs and oxygen saturation readings. Blood pressures in newborns are not necessary. However, blood pressures as they step out of that neonate time of above a month old will give you another tool in your toolbox to check and see how their cardiovascular system is going. And then finally, anticonvulsant medications, consult with medical command. Phenobarbital or phenytoin, lorazepam, Ativan, any of the benzos, but again, consult with medical command before you're giving any type of anticonvulsant medication to a newborn. I think at that point, we're going to stop here at thermoregulation, slide number 74. I don't want to hold you over. It is 9:59. I'm assuming you will get instructions from Rick once I'm done here, I'm assuming.
Yeah, just tell them I'm gonna process this and get it uploaded. That way you can review it if you want. If not, we'll convene back here Wednesday night, 6 o'clock.
Okay, very good. Anybody have any questions before we go here? We're still online. I can see you're chatting if you want. Any questions, please post them. You're welcome, Sam. You're welcome, Brandon. Welcome, Robert, Maria. I appreciate it. Hope it was okay for you guys, and I'll see you guys again on Wednesday. Take care, folks. Mute myself, Rick, or... Oh, thank you. Sorry.
No. Okay. I was helping Connor.